Hello everyone, it's me Dr. Mazhar and today in neurology, so it's our first medicine lecture about neurology in which I will talk about meningitis. As my previous lecture is there is a medicine lecture as well, like in Brown-Scott syndrome and diabetes mellitus complication. So this is also a medicine lecture of about meningitis. So actually, what is a meningitis? First of all, I would like to talk about definition, and then I will talk about its pathophysiology and clinical features and management. So I will go like that. So let's talk about its definition. So it simply is defined as the inflammation of leptomeningeal. So what's the meaning of leptomeningeal? Leptomeningeal meaning that the inflammation of pyometer. Okay, this is not a parameter, this is a pyometer. Okay, so inflammation of pyometer and arachnoid matter we call what? Leptomeningeal. So inflammation of pyometer and arachnoid matter collectively we call what? Leptomeningeal. So this is the inflammation of what? This is the inflammation of leptomeningeal layer. So meningeal layer consists of three layers including dura mater, arachnoid mater and pyometer. But in that meningitis only two specific meningeal layer will be affected. That will be the pyometer that is attached with brain, arachnoid mater that is attached with pyometer, and so this is the main meaning of this definition. So dura mater is most less likely can be involved. So this is the anatomy that in which how the meningeal layer will be affected. So first of all, I would like to talk about the basic structure, and after this then you easily understand what's going on in that disease or in that condition. So actually this is our brain. The brain, this is the pyometer. So pyometer covering the what? Pyometer covering your soft brain. So that's why it is a pyo means soft. So it is a soft layer that connect with brain, and this is we call arachnoid matter, and this space we call subarachnoid space, and this is we call what? Dura mater, and after dura mater there is a skull bone. So between the pyometer and arachnoid matter there is a space we call what? Subarachnoid space. In that space there is a CSF production and CSF presence. So in the subarachnoid space there is a CSF, not production in the ventricle. Okay, so in that space there is a presence of subarachnoid CSF. So in that space there is also one important structure pass through. That important structure we call optic nerve. So optic nerve is also passed through that space, and then they innervate the eye. So actually optic nerve is not a true nerve, is an optic tract that already I discussed in the optic tract system. So that's a basic anatomy. So if someone develop inflammation here, so that inflammation can result or can compress what? Cortex. So cortex become little bit depressed. Why? Because meningeal inflammation dilate that whole area. So that whole area dilated, as a result they push the cortex inward. When they push the cortex inward, so clinical feature will be appear. So actually when there is a meningitis can be happen, so suddenly any clinical feature can be happen. So that inflammation can depress cortex region. So this is a basic anatomy and what's going on meningitis. So this is very important thing. Okay, so now let's talk about what are the causes of meningitis. So actually there is a most commonly due to infectious agent. In every age group infection causes will be different. For example, if some in neonates the causative agent which cause meningitis we call group B streptococcus or E. coli. That is the most common cause of infectious cause of meningitis in neonate, mean in 28 days of neonate. After delivery up to 28 days we label that neonate what? Neonate. And then there is a Neisseria meningitis. In Neisseria meningitis, in which there is a happen in the children, and then there is a Streptococcus pneumoniae in the adults and elderly. This is all about the infectious cause. Now I talk about the other causes, like if someone develop middle ear infection, like otitis media. Why? What's the link between middle ear infection and the brain and meningial? Because in the middle ear superior border there is a tympanic bone. So any infection which are present in middle ear, so they easily travel from that bone into the meningeal. So in the meningeal they cause infection. So middle ear infection complication can be Bell's palsy, can be facial palsy, or can be meningitis. And nasal trauma, because if someone develop nasal trauma, there is a olfactory bulb, so they relate with meningeal layer, so patient develop meningitis or head trauma. So now talk about the clinical features. So what's the clinical features in that disease? So actually in that disease there is a classical triad. That means that clinical feature must be present in that patient body, or that clinical feature confirm our diagnosis. So that clinical feature will be what? There is a headache, neck stiffness and fever. So this is the triad. And then there can be vomiting because vagal stimulation become altered mental status, patient become confused, and there is a photophobia. Why photophobia? Because as I already told you, in the meningeal layer in subarachnoid space there is an optic nerve. So when there is a inflammation of meningeal layer, that inflammation compress or irritate the optic nerve. As a result, patient develop light sensitivity. So this is a photophobia. So this is our clinical feature, like fever, high grade, neck stiffness and confusion, increased sensitivity to light, and nausea and vomiting. So in clinically, how you can examine the patient if someone develop that sign, that if someone develop meningitis or not? So actually that sign which I talk about now, that sign present in 50% of patient and 50% of patient not present. So if there is no that sign like Bruzunkin sign or Carnegie sign, if there is no presence of that sign, so you cannot exclude the meningitis. Why? Because that sign can be present in 50% and in 50% that sign cannot be present. So actually in Bruzunkin sign what happened? Actually in that sign you are flexing the neck. When you flex the neck, so automatically there is a flexion of the legs. Why? Because when you flex the head, so they cause pain. So as a result, there is a spasm of hamstring muscle as well. So there will be what? There will be the flexion of the leg as well, or knee joint. There is a flexion of knee joint as well. There is an extension, so their knee joint will become little bit flex. So that actually we are trying to flex the neck region, but as a result, as a reflex, they lead to what? Flexion of the legs region. So this is a Brozunski sign. If that Brozunski sign will be absent, you cannot exclude, but according to clinical features, you can exclude. So this is about the main in examination when you try to diagnose the patient through your clinical skills. So you can do this sign. Then there is a Carnegie sign. In Carnegie sign, actually we are doing what? We are trying to flex the hip joint. When we do flexion of hip joint, so and we also trying to extend the knee joint, knee area, so patient feel pain, because we want also to extend that area, because now we are flexing that area and we also trying to flex that area as well. But when we are trying to flex that area, so they also cause pain, because when we are trying to flex that area, there is a spasm in the hamstring muscle. Here is the hamstring muscle. So actually we did this thing. For example, if I am a doctor and I am just flexing at the hip joint, and also I am trying to flex that here in that area, hip joint area, I am flexing the thigh region, and that knee area, when I am trying to flex at the knee joint area, so then patient feel pain. So I cannot So when I trying to pull that area a little bit upward like that, so patient feel pain. So this is the Carnegie sign, feel pain. Why? Because when I try to flex that area as well, because this area is already flexed and I want to try to flex that area. So that flexion, I try to flexion, but patient resist because patient feel pain. So that flexion lead to hamstring spasm and patient feel pain. So this is a very important sign as well. Then now how to diagnose that meningitis? Actually, to diagnose the meningitis, we are doing what? Lumbar puncture. In lumbar puncture, we do what? We perform by placing a needle between L4 and L5. We lateralize the patient toward the right side and flex at the hip joint as well. So at the between the L4 and L5 we are doing the lumbar puncture because spinal cord ends at L2 level. That's why we are selecting at the level of L4 and L5. So between L4 and L5 we take the CSF and do the CSF test. Then when we are trying to do the CSF, like we are doing lumbar puncture, so what are the layer crossing the needle? That includes skin, ligament, epidural space, dura mater, and finally arcanine. Now, what's the CSF finding? That how you diagnose either is bacterial or viral. When in the CSF, if you see when you did the CSF test and culture sensitivity and then the report came, then you check if there is a neutrophil increase with decreased CSF glucose level. When glucose level become less but neutrophil increase, they confirm there is a bacterial meningitis. But if there is a viral meningitis, lymphocyte increase with normal glucose level. So this is a position how you can also you can do in the sitting position and you can also do in the lying position, whatever you choose. But this location can more helpful, and we also give local anesthesia as well. See how it skin, ligaments, and then correct between the bone. I didn't talk about bone because there is no bone here. Now, what are the management of our meningitis? So first of all, there is a general measure, then there is a pharmacological treatment. In the general measure, we first of all bed rest, and then there is a IV fluid to prevent the dehydration and also maintain electrolyte balance because sodium, potassium very important for CSF as well. Fluid restriction if seizure will develop, because sometimes meningitis can provoke or can induce the seizure. So that's why we will fluid restriction, okay, and then control the fever, because in that meningitis there will be high grade fever. So we control the fever. Then pharmacological treatment, we do what? We choose the antibiotic like ceftriaxone. This is because ceftriaxone is the one which can also cross the blood-brain barrier. So that's why our drug of choice can be ceftriaxone and steroid like dexamethasone. So that's all about the meningitis. So I hope you understand. So if you have any question, you can ask me in the comment section. Okay, thank you so much. In our next lecture, I will talk about further in next disease. Okay, thank you.